Good morning, good afternoon, good evening, and welcome to this satellite session. I'm Wafa El Sadr. I'm the ICAP at Columbia University Global Director. And it gives me great pleasure to welcome you to the satellite today entitled Resilient Chronic Care Systems, Differentiated Service Delivery for People with HIV and Non-Communicable Diseases. This session is convened by ICAP's Sequin Network, the Coverage, Quality, and Impact Network, and it's supported by the Beckman Coulter Foundation and the Bill and Melinda Gates Foundation. I also would like to briefly introduce my co-moderator, Solange Baptiste, and Solange is the Executive Director of ITPC, the International Treatment Preparedness Coalition. This is an organization that has worked diligently to enhance treatment literacy and to advance community engagement and community oversight of HIV programs. Welcome, Solange.
Thank you, Wafa. Really excited about this session. I think that it's a quite timely topic, especially in the times of COVID, where we're looking at the primary healthcare and how communities, particularly the HIV actors, are all very much at the front lines of the response and how all the different parts of the health system work together. So really excited to hear from all of our speakers. We had a little bit of a glitch, so we're going to run straight into the pre-recorded sessions. I have everyone's name and very long bio, so I'm just going to abridge them so we can get into the juicy part of the session. So we're going to start off with a session from Dr. Miriam Rapkin titled Differentiated Service Delivery for HIV and NCDs. Dr. Rapkin is the principal investigator for the Sequin project at ICAP. She's an associate professor in epidemiology and medicine at the Mailman School of Public Health and director for health system strategies at ICAP. Dr. Rapkin has worked in the field of HIV and AIDS for over 20 years, focusing on strengthening health systems to improve quality, to improve the delivery of prevention care and treatment services for underserved populations. This next presentation, which will come right after, is from Dr. Cohen, Dr. Jennifer Cohen, on scaling smarter, resilient health systems for NCDs. Dr. Cohen is the Senior Vice President for Cardiovascular Health at Resolve to Save Lives, where she oversees the implementation of the Cardiovascular Health Initiative. She's a physician with a focus on improving access to and uptake of effective health products and models of care in low and middle income countries. And right after, we will move to a presentation now looking at leveraging DSD models to deliver integrated HIV and NCD care in Eswatini from Dr. Kambale from the Ministry of Health in Eswatini. Dr. Kambale is a differentiated care advisor seconded to the Eswatini National AIDS Program with support from Sequin. He's dedicated to scaling up DSD in Eswatini with a special interest in DSD for patients at high risk of disease progression. Thank you very much. And Wafa, you want to introduce you?
I'll follow up, Solange. We're just introducing the next two speakers to follow, and the talk to follow will be entitled Integrated HIV and NCD Testing in Kenya, and that's to be presented by Doris Odera Naitore. And she is currently a regional project director for the GeoTRH project at ICAP in Kenya, and she has several decades experience in the field of health systems and management and HIV/AIDS programming. And then, of course, last we have our speaker, Dr. Stephen Cusick, and he's going to be speaking on diagnosing blood cancers in low-resource settings. And Dr. Cusick is Associate Medical Director and Director of Contract Research and Director of Flow Cytometry at Phenopath Laboratories. After the presentations, you'll hear all of the presentations. Then we'll have a live panel discussion. So please do think of your questions as we move ahead, and you can enter your questions in the chat box. Thank you very much, and let's move on to our first presentation by Dr. Rapkin.
Hi, and thank you for joining us today. My name is Miriam Radkin, and I'm the Director for Health System Strategies at ICAP Columbia, an Associate Professor of Medicine and Epidemiology at the Columbia University Mailman School of Public Health. I'm really pleased to be providing introductory remarks for this exciting panel discussion, which will focus on resilient chronic care programs and ways in which to deliver prevention care and treatment services for both HIV and chronic non-communicable diseases. I have no conflicts of interest to report. Our panel has 5 presentations, and I'm honored to be joined by these esteemed colleagues. As you see, we have 2 cross-cutting presentations followed by 3 case studies. We hope you'll also contribute your own ideas and experiences during the live Q&A session. My task today is to make very brief remarks about the connections between these 3 topics, which my colleagues will explore in more depth. As many of you know, the term differentiated service delivery describes a strategic approach to HIV program design that balances the preference of diverse groups of people living with HIV with the recognition that a public health approach is needed to provide HIV services at scale. DSD models adjust key elements of service delivery, including service intensity, service frequency, service location, and service provider type, and they often de-link drug pickup from clinical visits. DSD models are tailored for context, population type, and clinical characteristics of people living with HIV. For example, programs designed for rural settings may look quite different than those designed for urban areas, and programs designed for people who are thriving on ART may look quite different from those who need close monitoring. Differentiated HIV treatment models can be individual or group models, based at health facilities or in communities, and led by healthcare workers or by lay people. At the top left, for example, are individual facility-based models such as Fast Track, in which rapid visits for ART pickup and symptom screening alternate with longer clinical visits. At the bottom right, you can see community-based group models, such as community ART groups or CAGs, in which individuals visit health facilities only once or twice a year and receive monitoring, medication, and support provided by peers in their communities. Emerging evidence suggests that DSD can enhance the coverage, quality, and efficiency of HIV service delivery. The Sequin Learning Network, funded by the Gates Foundation and led by ICAP at Columbia University, links 14 countries that are committed to scaling up DSD services and can provide us a snapshot of the scale-up of DSD models across diverse contexts. This slide shows some data from Sequin's annual meeting, which took place in late 2019, and illustrates the rapid scale-up of DSD treatment models in Sequin countries. Each row represents one of the countries providing data. As you can see on the left, the percentage of health facilities providing antiretroviral treatment that enrolled at least 10% of eligible clients in DSD models increased during this year in multiple countries. And on the right, you can see that the percentage of people on ART who were appropriately enrolled in less intensive DSD models also increased in more than half of the countries in less than 12 months. And this scale up is consistent with a recent WHO survey, which found that one element of DSD, multi-month ART dispensing, had been adopted in 128 of 143 countries reporting data. 9% of those countries gave 6 months of drug at a time, 6 MMD, and 61% used 3 MMD models. There's much more information about DSD at this conference, and I encourage you to explore all of these great presentations and posters. We could have a week-long conference just about the intersection of HIV and non-communicable diseases, the second topic, but I only have a few minutes to discuss it. But luckily, my colleagues will pick up the conversation in their presentations and provide deeper dives into specific issues. So I just want to highlight 2 key points about HIV and chronic NCDs, such as diabetes, cardiovascular disease, lung diseases, and cancers. Firstly, they coexist within populations, meaning that most health systems must deliver prevention, screening, diagnosis, and treatment for multiple chronic conditions. And secondly, many people have both HIV and NCDs, meaning that integrated programs often lead to higher quality services that are more convenient and acceptable to recipients of care. This slide speaks to the first point about co-located HIV and NCDs, and I've just excerpted data from the author's discussion of HIV and NCD prevalence in 44 countries to highlight the prevalence of HIV, diabetes, and hypertension in some of the Sequin member countries. And as you can see, it's quite high. So these health systems are confronting multiple chronic diseases. To the second point about the prevalence of NCDs amongst people living with HIV, this recent study illustrates high rates of diabetes and hypertension, as well as other NCD risk factors in people living with HIV in sub-Saharan Africa. And several of the case studies in this panel will explore integrated services for HIV and these NCDs. The last theme I want to highlight today is that by diversifying program design, by making it more client-centered and client-led and less health facility focused, we may be able to increase the resilience of chronic care programs in the face of shocks such as climate emergencies, violence, and outbreaks such as the current COVID-19 pandemic. This slide shows the devastating impact of the COVID pandemic on a wide range of health services, including both HIV and NCDs. And here, WHO data highlight disruptions in a wide range of health services, specifically for people living with HIV. We see that COVID-19 is affecting the supply of health services by interrupting procurement and supply chains and by infecting and killing healthcare workers around the world. It's also decreasing demand for health services as people stay away from healthcare facilities to avoid infection, and as lockdowns and travel restrictions prevent people from reaching their clinics and hospitals. So we have a poster at this conference which summarizes a scan that we did of Sequin member countries and their response to the COVID-19 pandemic. The poster has more details, but in brief, the Sequin countries moved very quickly to expand and modify their DSD models in response to COVID. The majority of countries expanded eligibility criteria for multi-month dispensing, and at least 3 enabled multi-month dispensing of medications for NCDs for people who are already in DSD models. And we see that the intersectoral collaborations and stakeholder partnerships that were involved in developing DSD models enabled a rapid and resilient response or set of responses that have enabled many people to maintain access to HIV treatment. So this issue needs continued attention and research, but it appears that by leveraging the lessons of HIV and DSD, we may have an important way to foster resilient chronic care systems. And the next presentations will explore this important issue in more depth. Thank you very much.
Hi, my name is Jennifer Cohn, and I'm presenting on behalf of Resolve to Save Lives on scaling smarter, resilient health systems for non-communicable diseases. So when does 50 plus 30 plus 0 equals 100? Well, when we say that, it means that globally we can save 100 million lives over the next 30 years by doing 3 things. Increasing control of blood pressure from 14% to 50%, reducing global sodium intake by 30%, and eliminating artificial trans fats to 0%. In this presentation, I'm going to talk about hypertension primarily. And hypertension is the leading risk factor for preventable diseases worldwide. It kills more than any other condition, including the leading causes of infectious disease, all put together. But we can prevent these deaths by reducing sodium and by controlling hypertension once it's diagnosed. Every 20 millimeters of mercury increase in systolic blood pressure doubles vascular mortality at ages 35 to 69. So if we can control that, we can prevent huge amounts of mortality in people in their prime of life. Unfortunately, globally, most people do not have their hypertension under control. So this is a cascade that many people in the HIV community will be very familiar with. However, this is the hypertension cascade. And whereas 1.4 billion people are estimated to have hypertension worldwide, we only have less than 14% under control. Now, we at Resolve to Save Lives believe there are some sustainable building blocks for resilient health system for chronic care, such as hypertension. And I'm going to present those here. And I'll also talk a little bit about some additional building blocks that we can use to make sure that essential services are delivered during the COVID epidemic. So number 1, we need to institute sane intervention guidelines. And when I say sane, I mean simple, algorithmic, affordable, non-toxic, and effective. All things that are very, very familiar to the HIV community. We need to rapidly incorporate and learn from what has been done in HIV and scale differentiated service delivery models, such as multi-month distribution, community drug distribution, and in the context of COVID, no contact community drug distribution. We need to utilize and strengthen digital health for patient and system monitoring, including use of telemedicine, to make sure we're tracking key indicators and keeping up that communication with patients, including at the community or decentralized levels. We need to bolster referral systems for those patients who do need a higher level of care while maintaining the vast majority of patients at that lower level of care or at the community care level to make sure that care is rational and sustainable. And we need to adapt our procurement and supply chain systems to make sure that the medications are there closer to the patient where they need them at those most decentralized points. In the case of COVID or other disruptions, we also may need to re-quantify and even increase buffer stock. And then a couple building blocks that are a bit more COVID specific. In terms of community engagement, of course, this is something that is always needed. We need the input of community always to make sure that the models we're building are fit, rational, and sustainable. But here we also need to learn from the community and communicate safer ways to access these essential health services, and then also reinforce to both the community as well as the system that essential services are just that, they are essential. And then finally, once we define these essential services, we need to make sure that there's a safe delivery of care. And that includes infection prevention and control, as well as triage of patients at the healthcare entry points and PPE for healthcare workers. And this is not just a one-way street, this is a two-way street. We want to be preventing deaths regardless of the cause. And so we have to be weighing, making sure that people can access health services with our restrictions to prevent COVID morbidity and mortality. But COVID has definitely leapfrogged us in the NCD world and in the hypertension world towards DSD models. Before COVID, in many countries, we were not even giving out even 1 month's prescription. Now we've had to actually shift radically and rapidly to adopt to the COVID response. And this has brought us actually towards potentially more sustainable models of care and DSD. So what have we done at Resolve? Well, in terms of the COVID response, we're beginning to do home blood pressure measurements and even screening by community health workers. So task shifting, decentralization, community-based care, of course, with appropriate PPE. We've also begun community distribution of medicines. And we've begun multi-month refills. Now, finally, this is a very exciting intervention, which is actually use of telemedicine, which has picked up very dramatically in India, where a person in their home or in their community can actually access a doctor at the higher level of the health system and change their prescription if their blood pressure is not under control, transmit a concern or an adverse event and get that under control, all again while maintaining a patient-centered care and something that is rational and sustainable for the health system. So this is extremely exciting news. What we want to do in the NCD world is see if we can learn from all of this and bring it towards scale. Now, within HIV, there's also a growing burden of NCDs. So this is a table from Helen Bygrave's recent article that shows that in countries with high burdens of HIV, we are also seeing very high burdens of hypertension and also of diabetes. So these are beginning to be recognized syndemics. And of course, this is something we have to address to make sure we're providing holistic care to our patients living with HIV. Now, this is not only something we have to deal with now, this is going to be something we're going to have to deal with in the future, and even more so. This is a modeling study from Zimbabwe that looked at rates of hypertension and other NCDs among people living with HIV, as well as the general population not living with HIV, now in 2018, or very recently in 2018, and looking towards the future in 2035. And if you can just look at the hypertension bars, both the green, which represents HIV negative individuals, as well as the yellow, which represents HIV positive individuals, we are going to see a dramatic increase in the rates and the prevalence of hypertension in both of those populations. So we need to begin to build these systems now so that we can prevent and deal with this burden of disease in the future. And very similar modeling has been done in Kenya. So there are a number of demonstration projects that have shown that we can sustainably and effectively deliver care to people living with HIV for holistic care, including non-communicable diseases. And I'm just going to be presenting one of these projects, which is the Makerere University Joint AIDS Program, which is funded in part for this project through Resolve to Save Lives. And just to say, they actually have instituted a program that utilizes a lot of DSD models, but also tries to get complete coverage. So their aim was to screen all of the cohort for hypertension in 1 year, provide a very simple algorithm-based medication therapy, and then also, implement task shifting, DSD models such as extended drug refills, telemedicine, and community medicine distribution, some of which came in as a result of COVID. And as you can see from the cascade of care, they were very successful at getting 100% of patients screened. Now, 24% of those patients within their HIV-infected cohort were diagnosed with hypertension. That is an incredibly high comorbidity rate. Unfortunately, as a result of COVID, as well as some other issues, only 29% of these patients were actually initiated on antihypertensives. But once people were initiated, we saw 78% of those patients did achieve blood pressure control. So we can see this is feasible. Yes, we have some areas in the cascade where we need to block that leaky cascade, but this is, I think, yet another piece of evidence that shows we can effectively treat our patients holistically for all the diseases that they may present with. So in conclusion, differentiated service delivery should be applied as a public health approach across a range of non-communicable diseases, including hypertension. Starting and scaling with DSD models for NCDs can help us overcome barriers to uptake of care, particularly in unstable environments or where access to essential services may be compromised in the situation like COVID. And COVID-19 is actually forcing us to be innovative and leapfrog towards non-communicable DSD models. And finally, within HIV, there's an HIV NCD double dividend. Yes, we absolutely need to be providing very simple, very effective HIV diagnosis and therapy to people living with HIV, but especially as our cohorts age, we also need to be making sure we are treating the entire patient, providing holistic quality care, which will include diagnosis and care for non-communicable diseases such as hypertension. Thank you so much.
Good morning, good evening, everyone. My name is Evre Kambale. I'm working with the Ministry of Health in the Kingdom of Eswatini. I'm going to take you through the facility-based treatment club for people with both HIV and NCDs in my country. So as background, DSD coverage has been rapidly scaled up in Eswatini from 15.5% in December 2017 to 54% in December 2019. And as you can see, out of the 60,000 clients enrolled in DSD, we have the majority of these clients enrolled in fast track. That then followed teen clubs, family-centered care model, and community ART groups. The number of DSD models implemented in the country has also increased. This is to respond to specific client needs. So as background, there is a relatively high prevalence of non-communicable disease in Eswatini, including among people living with HIV. There is a research study which was conducted in Eswatini and South Africa, which showed that hypertension rates of 30 to 40% among clients aged 40 years and above, and these clients were taking ARVs. High prevalence of NCDs in the countries, including among PLHIV, has motivated the program to integrate NCDs services in DSD models with the aim of providing holistic, integrated care and improved quality of services. In this regard, the Ministry of Health in the Kingdom of Eswatini has decided to pilot an integrated HIV and NCD DSD models. So 2 regional hospitals have been selected to implement these DSD models. The selection criteria were based on their expertise of implementing facility-based individual and group models. Facility-based group models have been selected because it allows easy refill for both NCDs and NCD and HIV treatment. And psychosocial and peer supports characterizing these models were also important to be included in the pilot. Facility-specific SOPs has been adapted from the national SOP, focusing on most prevalent NCDs with highest health impact. And staff members working in the two facilities were trained and oriented through an in-country learning exchange visits. What were the eligibility criteria? So for a client to be enrolled into these models, the client was supposed to be on ARVs and NCD treatment for more than 12 months, and the disease was supposed to be well controlled, and the clients were selected based on the good history of their adherence to treatment, and clients with the most prevalent NCDs, including hypertension, diabetes, and asthma, were prioritized to be included into the models. So the models, the average number of members included in the models, it was 23, and the clients were meeting every 2 months. The meeting were conducted in the health facilities, and it was involving nurses and expert clients. Files of clients with NCDs has been identified and flagged during the baseline data collection process conducted before the implementation of the models, with the objective of actively recruit clients into these specific DSD models. So I'm going to take you through the data we have collected so far. So in the two facilities, we have 164 clients enrolled into the model, and 73% of these clients were female and 27% were male. As in the previous study presented during this presentation, we can see that the majority of clients enrolled in the model are aged more than 60. We have 39 clients with hypertension, 9 clients with diabetes mellitus, and 19 clients with both disease, hypertension and diabetes mellitus. So followed clients aged 50 to 59, and then lastly, clients aged 40 to 49. So I'm going to dive through data in the specific facilities. I'm going to start by RFM Hospital, where 108 clients were enrolled into the models. On my left, I have a graph showing the total number of clients enrolled by age and sex. As you can see, the majority of clients were female, and most of them were aged more than 60. On my right, I have a graph showing the total number of clients enrolled by type of NCDs, and the majority of them were having hypertension, followed by clients with both disease, hypertension, and diabetes. And lastly, we have clients having diabetes only. And for this group of clients, you can see that there were more male than female, but hence the difference is not significant. So in Peak Hospital, we have almost the same pictures. We have 56 clients who were enrolled into the model. The majority were female, and the majority of clients were aged between 50 to 59. And on my right, the total number of clients enrolled by type of NCDs, we have the majority of clients were having hypertension, then followed both disease, hypertension, and diabetes. And then lastly, we have clients enrolled in diabetes, having only diabetes. So what were the lessons learned? We learned that assigning specific facility staff to each club allowed close monitoring and follow-up of clients. And it has also assisted to build client confidence and adherence to treatment. Clients with poor adherence were actively moved back to mainstream for close monitoring and step-up adherence. This was to make sure that these clients, even though they were not adhering to treatment, but they were supposed to be maintained into care. The model has also allowed shifting of NCD management and monitoring to nurses, because the NCD guideline is prescribing that clients with NCDs are supposed to be reviewed by medical doctors. But this is a good opportunity to shift the task to lower cadres who are nurses. The model opened the room to integrate other screening, preventive, and curative services. This includes, but not limited to, cervical cancer, family planning, and TPT. And also, the most important lesson we learned that pre-packing of medicines has consistently reduced client waiting time and health providers' workloads. But as challenge, The limited stock of NCD drugs in the facilities is also one of the limitation in the implementation of these models. Because facilities are having limited stock of medicines, that is why the clubs are meeting every 2 months. So facilities were not able to refill 3 months as for the ARVs. And to align the two treatments together, that is why the clubs are meeting every 2 months. That was my last slides. I thank you for your attention, and I'm ready to receive your question. Thank you.
Good morning and good afternoon, everyone. I am Doris Naitore from ICAP Columbia University in Kisumu, Kenya. Today, I'll be presenting the multiple disease screening at Jaramogi Oginga Teaching and Referral Hospital in Kisumu County of Kenya. I have no conflict of interest as I am presenting this information. My presentation outline is the rationale for multiple disease screening, the staffing that we've been able to put in place for this service, the establishment of the service, monitoring tools, the cost of establishing the service, the achievements that we have made so far, and the lessons that we have learned from setting up this service. The multiple disease screening tool service is based within prefabricated booths, and it began in the referral hospital in March 2017 to offer health screening for the general public. The rationale of setting up this service is to provide HIV testing within the context of multiple disease screening to ensure we destigmatize HIV and provide screening for all other non-communicable and communicable diseases. It's also a program or a service that provides an attractive multi-component service to increase HIV testing acceptability for men. The staffing component of the service is simple. We have an HIV testing service supervisor, the service providers, and the community health volunteers. The components of the service include offering the clients a BMI screening program, blood pressure screening, TB screening, diabetes screening, and finally, we provide them with an opportunity to take an HIV test. The services are centrally located close to the hospital gates with extended hours of service from 8 a.m. to 9 p.m. It also offers weekend testing or weekend services. We offer within the service referral to other services like PrEP, VMMC, Gender-Based Violence Recovery Center, and also screening now for COVID-19. It's a friendly, non-judgmental approach to services, and we offer an opt-out HIV test within the program. Once we do the screening procedure for the client, and the client has a high BMI, the client is immediately canceled and referred to a nutritionist. If the client has been offered a blood pressure screening program and the blood pressure is high, immediately they are referred to the outpatient department. If the client has had a TB screening process and the TB is screened, they are referred and they have a positive TB screen, they are referred to the TB clinic for further management. When we screen the clients for diabetes and they have a suggestive symptoms, we refer them to the medical outpatient clinic to receive specialized care from specialized physicians. And finally, if the client has a positive HIV test, they are linked to the patient support center and offered antiretroviral therapy. If they are negative, we do not stop there. We provide them with PrEP, VMMC, and also market the other services that are offered within the hospital for the clients to get free medical care. So we have various monitoring tools that we use. We have the nutrition screening algorithm, the blood pressure screening guide, diabetes screening guide, the gender-based violence screening tool for physical violence and emotional violence. We have a health check register. We have signages and posters and flyers that we have placed strategically within the hospital. This is a picture of a health check session that is going on within the services that we offer. Some of the data that we have collected, and this is data that I am presenting for a month in October 2019. We screened 2,964 clients, and of these, 2,883 were eligible for HIV testing services, and all were tested. 45 of these patients were HIV positive, and 43 were linked for care and treatment within the patient support center. From this graph, you can see the number of females and males accessing this service is quite high. From this graph, you can see that the number of males and females accessing services within the weekend is equally quite good. And from this graph, you can see that testing for couples has been quite encouraging from October 2019 to date. The outcome also for other non-communicable diseases like hypertension, diabetes, TB, and nutritional obesity is quite good. We have tested 68 clients with high blood pressure and referred them for appropriate treatment. We have tested 17 for TB, referred them for TB treatment. 1 had diabetes, and 23 had a BMI and are undergoing nutritional support. The cost of establishing this unit is quite minimal, approximately $5,700 US for a complete setup of 1 booth. The lessons that we have learned from this program is quite encouraging. The multiple disease screening provides a non-stigmatizing environment for HIV testing. It also provides extended hours that includes opportunities for men to seek health intervention. It also helps to detect other chronic diseases like hypertension, diabetes, TB, and other communicable diseases like COVID-19. It's also a tool or a service that is popular and of high demand for the general public. I would like to acknowledge the Ministry of Health, Jaramogi Oginga Teaching and Referral Hospital, our funder, PEPFAR, and ICAP that has been implementing this program together with Jaramogi Oginga Odinga Teaching and Referral Hospital. Thank you very much.
Good morning, and thank you for the opportunity to present the work that my collaborators and I have been doing to leverage existing HIV lab capabilities to transform cancer diagnosis in sub-Saharan Africa. I am a full-time hematopathologist and employee of Phenopath Laboratories in Seattle, although the work I'll be describing is completely unrelated to my responsibilities at Phenopath. So as I think we all know, the burden of non-communicable diseases has been rising in sub-Saharan Africa over recent decades. In this recent review of the previous 3 decades, we can see a marked increase in the burden of all NCDs, about 67% over these 3 decades. and particularly for cancers at about 80%. And in addition to a general increase in the burden of these diseases, there continue to be significant disparities in outcome between sub-Saharan Africa and affluent countries. So this is data for pediatric Burkitt lymphoma. And if one looks at these survival curves from American children, one can see a long-term survival of 85 to 90% using standard of therapy. You contrast that with children with the same disease in Malawi, where the long-term survival is only about 30%. So contributors to this disparity include access to chemotherapy, access to other medical care, supportive care, comorbidities such as malaria, childhood nutrition, but an important additional contributor that's under-recognized is problems with cancer diagnosis in sub-Saharan Africa. And the problems in diagnosis kind of fall into two main categories. The first is diagnostic delay. A major contributor to that is just a shortage of pathologists like me, the physicians who do cancer diagnosis for a living. On a per capita basis, there are roughly 50-fold fewer pathologists in Uganda than in the United States. In addition, the materials required to process tissue to make the glass slides that is the basis of most pathology may be in short supply. As a result of this backlog, diagnosis at public institutions often takes a minimum of 1 to 2 weeks and often up to a month for cancer, which is too long, especially for aggressive cancers like Burkitt lymphoma. And while private labs do exist, they're typically unaffordable. In addition, misdiagnosis is a major problem. So in this review of 100 purported cases of Burkitt lymphoma that I participated in, a full 20% of these patients were misdiagnosed. And if one compared the survival of misdiagnosed patients with correctly diagnosed patients, we see that the misdiagnosed patients fared substantially worse. And that's obviously because the incorrect disease was being treated. So in thinking about how we can remedy this, as a hematopathologist, I immediately jumped to thinking about flow cytometry as a modality that could help with this problem. So flow is a basic technology, a standard of care for how I diagnose leukemia, lymphoma, and myeloma in my practice. And perhaps most importantly, there's a robust flow cytometry infrastructure in sub-Saharan Africa because of HIV monitoring. A major advantage of flow cytometry is that it uses fresh patient samples requiring minimal processing, which enables diagnosis to occur in hours rather than days to weeks. So we were able to develop a robust assay using state-of-the-art instruments and consumables over about a 5-year period, and launched this assay at the Uganda National Health Laboratory Service in Kampala in December of 2018, and about 2 months later went live with actually reporting patient results. So the experience in Uganda has been as follows. We've tested about 200 patient samples. About 30% of these are life-threatening acute leukemias, so a much higher proportion than I see in my practice in Seattle. We've trained Ugandan pathologists to analyze and report the cases, and I act as a full-time consultant on difficult cases. Because of the speed of diagnosis, we can transmit acute leukemia diagnosis to oncologists in 48 hours or less. And if we assume about a case a day or 250 cases a year, we believe we can operate this laboratory on Kampala for about $60,000 a year, which seems very reasonable for such high complexity testing. This is just an example of the readout from a case. Each little dot on these plots is a viable human cell that's being evaluated by flow cytometry. And this cluster of black dots along the bottom of these plots is actually, this is a case of multiple myeloma in an HIV positive patient. And really, I can look at these plots in 5 seconds and know the diagnosis. So the response has been terrific from Ugandan hematologists and oncologists. Basically, we are giving them the ability to classify a disease and offer the best treatment options, which is something they have not been able to do before. In terms of next steps, we are launching a second lab in Eldoret, Kenya. We do ongoing weekly training with both the Kampala and Eldoret teams to increase the level of expertise. In January of 2021, we plan to transition to a higher complexity assay that rivals anything that's being done in the United States. In parallel, we've made efforts to bolster traditional glass slide pathology. And a real game changer in this area has been being able to use digital imaging to actually image an entire slide in sub-Saharan Africa and have an expert anywhere around the world look at it and render an opinion. And of course, the overriding goal is to make these laboratories sustainable beyond my involvement. And then finally, I'd like to thank my many collaborators in Uganda and in the United States for bringing this project to fruition. And with that, I will thank you for your attention.
Thank you, everyone, for such a wide range of very insightful presentations. You're speaking my language for sure when you speak about the whole person and not just one aspect of their health. We all know of unfortunate situations and stories where people are virally suppressed, but yet they die of a heart attack because of lack of poor access or good screening. And so we also think back to listening to the presentations also made me think back to like the weight gain issues around when we were looking at DTG and obviously the risk factors associated with COVID now. So this definitely lands squarely on diversifying program design and differentiated service delivery for HIV and NCDs. So it seems like an obvious thing. I think everyone here and even our audience will fully agree that this is what needs to happen, but why is it not happening? So I think I want to start back to Miriam, who seems like she spoke so long ago. If countries and communities are interested in starting to do DSD or advocating as communities for DSD or expanding programs and models, where should they start? What is a good approach? How do you even get to this?
So thank you. I think that's a great question. I don't think there's one answer that will work everywhere, but I do think that pointing to the experience of models that exist, whether that be HIV or some of the hypertension programs that Dr. Cohn mentioned, building on the lessons that we've learned in the last few months during the response to the COVID epidemic, and really making the point that person-centered care is better for everyone, that being able to have things like different models for different for people with different preferences, to have more community-based services, particularly for chronic illnesses that people are going to have for 10, 20, 30 years, and particularly for people who are well managed, right? It's a little easier for the clinicians to let go a little bit if there isn't a relevant evidence base, and if the patients recipients of care, are thriving on their current models. So I would say looking to the evidence that exists, really making sure to engage communities and recipients of care in the design of programs, and trying to bring together the sort of disparate parts of the health system that deal with, HIV as a communicable disease and other illnesses as non-communicable diseases, sort of reframing as chronic diseases.
Thank you very much, Miriam. I'll move on to ask the second question, and I'll address the question to you, Jennifer. Thank you very much for your excellent presentation as well. And it was really heartening to see how the lessons learned from HIV are kind of being adapted and tailored to responding to hypertension in particular, a very deadly and common disease. And also building on the platform, the HIV platform. So both the lessons learned, but also building on the platform established by HIV and trying to take advantage of this. And I'm just curious in your thinking, as you've been thinking of adapting and tailoring the HIV response to hypertension as one example, are there differences that come to mind between those two conditions, something that doesn't adapt well? Are there other things that can be adapted easily and so on?
Great, thank you so much. So I think that it's really interesting because, at least in my experience, and I'm coming from the world of HIV, I'm an infectious disease doctor until very recently was working in HIV, there are so many similarities here. Now, I think that where we have not actually advanced in the realm of hypertension and other non-communicable diseases is really in kind of some of the treatment simplification and optimization. And there is a place where I think a lot of strides can be made to come forward with one optimized treatment that can be applied across a great deal of populations with minimal drug monitoring, and really allow that sort of flow that would come down to allow DSD models, including the decentralization, the task shifting, the reduction in appointment spacing, and the reduction in laboratory monitoring. So whereas I see that there's more overlap than there are differences in actually kind of the models of care, I see that we actually still have kind of a ways to go in some of some of the basic tenets that would allow DSD models to be taken up in terms of hypertension. Now, I will say that because hypertension is provided as part of kind of integrated care, primarily in the OPD, and not as part of vertical stream programming like HIV is in many countries, there are pros and cons to that. So it's difficult to just say we can do these DSD models for hypertension, but then not for other common diseases that people are being seen in the OPD for, such as diabetes. And so as we advance, I think we really need to think about how do we apply these kind of commonalities, common models and approaches to care across chronic diseases, and not kind of replicate vertical streams that may not actually be applied as well to an OPD type setting as opposed to an HIV clinic type setting. But thank you so much, and thank you for inviting me to this presentation.
Thank you.
Thanks, Jen. Dr. Kambale, maybe I can switch to you now. In the Kingdom of Eswatini, I just like to say that.
Yes.
Were NCDs limited to hypertension and diabetes, or did it just turn out that way? I think it's interesting to think about this not just as from the DSD perspective or from the clinical management perspective, but also something you mentioned in your slide, which was about the access to the medicines for NCDs, and actually just talking about one of the basic things, having the medicines there. So the availability of the screening and the medicines, so the diagnostics and the medicines to be able to manage. Can you talk a little bit more about that?
Okay, thank you, Solange, for the question. So initially, it was not limited to hypertension and diabetes. But also we guided our choice because of the evidence which was out there, because people on ART are aging and they have more NCDs. And we prioritize hypertension and diabetes because of the highest number, and also because of the impact those two NCDs has on people living with HIV. That is why our priority and our focus was on the two diseases. But as I mentioned, this model gave us an opportunity to learn how to integrate other services, other NCDs. And in our plan, we are planning to extend to other diseases. And also the other thing is that because we have the BP machine in place, we have fast blood sugar in our head, we can easily follow up at each visit and take a quick decision. But you are right, because the NCDs is not only limited to those two diseases, but our plan is to have integrated other services as well, including asthma and other NCDs. Thank you.
Thank you. And I'm moving now to you, Dr. Kusik, and thank you very much for the highlighting of the challenges, in particular of diagnosis of cancers in low-middle income countries. And it's a huge challenge, and your work is remarkable. I have a question as to, many countries in sub-Saharan Africa, cancer diagnosis and care is very centralized, usually at specific a few laboratories like the national lab, or at one national cancer hospital, for example. And I'm just curious, your thoughts in terms of, if we really want to enable people, broader population or larger coverage of these diagnostic methods and management and so on, what are the options for decentralizing such efforts from the current very centralized model?
Yeah, thank you for the question. It's an excellent question, just in terms of getting the service out to as many people as possible. I think we're fairly fortunate. In Uganda, they have a pretty good kind of hub and spoke, just specimen transport system, and it's not an enormous country. So I think, from what I understand, that in terms of getting samples from acutely ill patients, even farther afield from Kampala, that works fairly well. But it's certainly going to be a challenge in potentially other places. I think and as a lot of the discussion has occurred today, a lot of it gets back to the local clinics and the recognition by local care providers that cancer is a possibility. I mean, the program that I work with really started an effort to diagnose Burkitt lymphoma, which is the most aggressive of all human cancers, endemic Burkitt lymphoma, particularly in children, more rapidly, because a lot of these kids are just dying out in the villages. And again, even if you look at all the constellation of causes of jaw masses in children, it's still more likely to be a dental infection than Burkitt. So just getting people to think about it, this really goes back to even recognition of potential that somebody has cancer. So the one beautiful thing about the system we put in place is the data files are actually small enough in terms of the flow cytometry files that they can be sent by email to me, so I can get them or in real time. So if one can, and the system, the assay we've developed is completely cold chain independent. It's prefabricated, actually internationally, through our collaboration with Beckman Coulter. And so really, if we can get an instrument, even at a local health center, and we have a medical technologist that we can train up, the data could even potentially be generated locally. And it doesn't necessarily require, really high complexity centralized testing. So it could be decentralized if the economics allowed it.
Thank you.
Sorry, just going off mute. Can we switch now to Kenya? So Doris, I just wanted to quickly check in with you. Let me pull up my question, which is all of a sudden disappeared. So the pilot, so we come back to our fun question about scale and sustainability. So we have our pilots and they do well. So I guess the question that is applicable here is, do you think that this pilot is scalable? And are there any plans to provide multi-disease screening at other hospitals and clinics in Kenya? Can you talk to us a bit about that?
So thank you, Solange. And that's a very nice question that you brought up. We actually have been able to share our lessons with other PEPFAR and government partners. And this model has been scaled up all over Kenya. We were the first model in Kenya, and we were able to have visiting teams coming from all the 47 counties in Kenya, and they've been able to embrace this model, which is very successful in the whole country. About sustainability of the model, we've continuously ensured that the hospital management team has been involved in taking up more and more responsibility in management of these booths. Right now, 50% of the management or the healthcare workers that are deployed within these multi-disease screening booths are people that are employed within the county health government. The hospital also takes up the cleaning of the booth and the supervision of the booth. And eventually we hope to hand over the clinics or the multiple disease screening booths to the hospital.
Thank you very much. Wafa, do you have a question for Todd? If you don't, I do.
Go ahead, Solange, of course.
We're in the vein of the future and scaling things. So Todd, I guess we can ask you, what do you see as the future of cancer diagnostics in sub-Saharan Africa?
Wow, that's a great question. Thank you. Well, I think it's going to be partnerships like Beckman Coulter has established with Dr. Cusick. I think those kinds of partnerships are a great way to get technology that Beckman Coulter has disseminated to places that otherwise may not have access to it. So I think it's these kinds of partnerships that are going to be critical in the future. Thank you for the question.
Thank you.
I think we have maybe a couple of more minutes, I believe. Miriam?
I have one. Yeah. Okay. Go ahead.
I have a question for Dr. Cohn.
Yes.
Go ahead.
So Jennifer, you mentioned something that's sort of very interesting to me, which is home-based blood pressure monitoring. Mm-hmm. I'm wondering if you've also had any experience piloting or studying blood pressure self-monitoring by people with gadgets like wrist monitors or others.
Thanks, Miriam.
Since we're talking about the future.
Yep, it is. That's absolutely the future. So actually, there are several larger programs being trialed out, including in China, to look at distribution of semi-automated or automated digital blood pressure monitoring devices for home monitoring. And I think the link between that and telemedicine is a really tantalizing avenue of the future, and how much of this care can we move to self-care to really make this as person-friendly and as rational from a healthcare perspective as possible. Now, you know, in the past, there have been some questions around the validity of self-monitoring for blood pressure. Some of that is the wrist monitors tend to be a little less accurate. And some of that is actually just in training a person to actually position themselves correctly and get in the right environment. So we're trying to really look at that and, you know, review any additional data that comes in. I think there is good data that community health workers and lay health workers can actually get accurate blood pressure monitors in the community and household level. And I think the next level will be to see if we can get the same accuracy and fidelity from home blood pressure monitoring. But I think it's a great question for future research and discussion.
Yes, thank you very much. If my mother can do it, anybody can do it. But I just wanted to ask, Rafa, if you'd indulge me, one other, maybe a rounding up question about something. I think, I can't remember who was it that said it, that when the clinicians could let go. Who said that? Can't remember who said it. Yes, Miriam, you did. But I think this question of the person being able to take the leadership in their own health. Like, obviously for me, it goes back to that question of community's role and treatment education. If we can teach people about viral load and viral load monitoring, and knowing that you should be able to know your blood pressure, what is good, what is a good reading for your diabetes, when you measure your sugar levels. So you should be able to, we should be able to educate people about these things. To what extent do you think clinicians truly have to let go so we can actually shift and actually scale and stop talking about integration and diversifying programs and actually do it? Do you think that's a role? There's a place for that? Maybe even Wafa can answer, and then I'll be quiet.
I think it's interesting you mentioned this, Solange, because I was when I was listening to the talks, it dawned on me that one of the critical things from HIV lesson learned is task shifting and community engagement. I mean, they go hand in hand, and I feel sometimes that it's been to the disservice or to the disadvantage of non-communicable diseases, whether it be hypertension or cancer, is that we haven't had, I think in many countries, certainly in the US, there is advocacy and engagement and so on, although there's not as much really task shifting. But there has not been as much of an embrace of this letting go and shifting to other cadres, engaging community workers, engaging the community, self-management principles, focusing on literacy, as you're saying, as there has been in the HIV arena. Even we're not perfect in HIV. We have a long way to go, as all of you well know. But nonetheless, those have been kind of the foundations of what enabled us to scale up and be able to have coverage and hopefully with quality and most importantly, impact. So I do think there's a ways to go across all of these entities in further really letting go to enable people to take charge of their own health and do it well. And I think it can be done. It just, we have to trust them and let go, I think, sometimes of the medical model where people are sort of can't believe that it's that it's at all possible that a person could do X, Y, and Z. We've learned again and again it can be done and done well. So I think that's the new frontier. And I think if we come together as people who are passionate about HIV or passionate about non-communicable diseases or passionate about both and all and passionate about people's health, is that I think we should really push along that frontier and try to really enable that this will be cross-cutting in principle across all of these entities moving forward.
Thank you very much. I think we have to wrap up here. We're out of time.